Good afternoon, everyone. If you could come on in and take your seats, we're going to try and get going. Feel free to get up if you like and get more food, and as the program goes on, there's no need to stop eating while we're talking. Let me start by thanking all of you for coming out to this kickoff meeting of what we're calling right now an East Baltimore Health Assessment. For those of you who may not know, my name is Chris Gibbons, and I am one of the associate directors here at the Urban Health Institute at Johns Hopkins. Phil Leaf, to my left here taking pictures, is the senior associate director at the Urban Health Institute. Amy, you want to wave your hand? Amy Goad is a project manager at the Institute, and I think Quinn Gentry, Quinn, you want to raise your hand, is one of our postdoc fellows. Am I missing anybody? I hope not. If I am, forgive me. But there are a few other members will be floating in. Our director, Dr. Bob Blum, is out of the country right now, so he's not with us, but he actually may be with us. This event is being streamed live, and he promised that he's going to be watching online. So, Bob, if you're there, how you doing? Let me say, first of all, that all of us here either live, work, or care about the East Baltimore community. We share a desire that East Baltimore will become a better place. For some of us, it's a part of the jobs that we do here. We work to help people living in East Baltimore and other places become healthier. For others, it's a part of the research that you do. For still others, it's just a part of your life. You live in the community and you just want the place where you live to be a better place. And still, for some others, it's an absolute passion. It drives everything you say and do each and every day of the year. But whatever your reason for being here tonight, you've come because you would like to see a better future for East Baltimore and similar inner city urban areas around the country. But this future, though, is tied to the realities of today, which we all know well, increasing urbanization and the footprint that imposes on people, a troubled economy in which so often people living in the urban inner city feel the brunt disproportionately, and rising healthcare costs. It's also rooted in the realities of yesterday. And for some, that means amazing advances in medicine and public health here at Johns Hopkins. But for others, it also means a legacy of denial and disenfranchisement. But your being here today indicates that your expectations, and I've heard these, that people have talked to me, that the expectations for this health assessment run from, on one side of the coin, it's an amazing opportunity to get your hands on some data that we couldn't otherwise get, all the way to the other end of the spectrum where this is an amazing opportunity to correct the wrongs that have been done in past years and centuries and fix the things and get the things that we should have gotten in times past. The challenge I would submit to all of us here tonight, the challenge is to balance the fact that on the one hand, this is about a health assessment. It's not a redevelopment plan for East Baltimore. It's not an economic empowerment plan for East Baltimore. It's not even a fix all that ails Hopkins plan for East Baltimore. But on the other side of the coin, it could be a tipping point for a new era in community academic research here at Hopkins. A tipping point is defined by Malcolm Gladwell as a time when a little thing leads to huge change. It leads not to just huge change, but change that's so big it can only be called disruptive. And disruptive change is that change that's so large that it's just not even possible to imagine it or conceive of it at the outset of what you're doing. This could be a tipping point in the relations. Not that this is the beginning point. This will build on the work that all of you have already been doing in the community. But perhaps, just perhaps, it will go farther, much farther, than even any of us imagine. And so for us at the Urban Health Institute, whatever this health assessment ultimately becomes, and it will be determined by each of us here, it is at least one thing. It is an opportunity. It is an opportunity to do something new. It is an opportunity to do something differently. And it is an opportunity to do something together with the community. You see, no one side of the coin, it's our intention and our hope and our plan that no one side of the coin, that is the Hopkins side or the community side, will control the entire process. No one side, quite frankly, is going to like everything that they hear. You see, one of the things that I think is important is that we be honest. And there are many here at Hopkins, some may even be in this room, that believe that in order to fix this community, we don't actually need community members. And, you know, on some level, they may well be right. There's a lot that Hopkins can do without interacting with the community, but I would submit to those that believe that way that part of the reason we have not improved the health indices more than we have is because we have not fully engaged the community to the level that we could. But on the other side of the coin, there are those in the community, some of which may be here today, who believe Hopkins is not part of the solution. Hopkins is the problem. And unfortunately, sometimes in the past and sometimes right now, unintentionally and perhaps intentionally, things are done that are not necessarily in the best interest of every community member. But I would submit to those community members that believe that way that yes, indeed, Hopkins may have been and continue at times to be part of the problem, but we can do more with Hopkins than you can do without. And so the challenge for us today is to create a common vision, to get engaged, to stay engaged. And I have no doubt that if we do that, the products that we will develop, the goals that we will achieve over time will be well worth the effort. Once again, thank you for coming here tonight. We have a lot of people here tonight. We had wanted to start with introductions, but with so many people here, that would eat up all the time, even if everybody took 1 minute. So we're not going to do that tonight. What we did do is print off the lists of everybody who indicated to us that they would be coming. So please take that with you. We provided it in your packets. It includes the contact information. So if somebody says something and you want to get in touch with them, you'll know how to do it. And feel free to make yourself known to each other as one way. There will be many opportunities, hopefully, as we go forward with this for people to come together and to talk. So this will not be the only time, but that list will be there. And as it grows, we will continue to share it with you. I prepared just a few slides to get us going. So what are the goals of tonight? We have about an hour and a half, and we intend to respect your time and let you out on time. But I at least have 3 goals for tonight. One is to talk about what we've learned about community academic partnerships and working in communities in the past. And when I say we, I mean we, not just me, not just Hopkins, it's all of us. And I'll tell you where that came from. But 2, it's not just to talk about the past, it's to cast a vision for this health assessment for the future. and then discuss a roadmap. How are we actually going to get there? It's one thing to talk about the future, it's another to start, it's actually another to complete. So these are at least my goals. There may be others, but this is what we intend to accomplish with you tonight. So, just to give you a quick background of what has happened over the course of this summer, as some of you know, this idea is not new to me, it's not new to here. There have been others who have thought about doing these things. Even I have been involved in previous attempts to do this that didn't go quite forward in completion. And so we held a series of community meetings, a series of meetings, one with the community and also one with Hopkins to talk, to just say, hey, we're thinking about doing this again, what do you think? Let me tell you that these are the three things that struck me, and you'll have an opportunity to input as well, that struck me out of that community meeting. The community said, and what I heard is, this is a great idea, but you're not going to be able to fully engage the community without an intervention component. We've been assessed to death already. Okay? We know what you do. You come, you research, you do your thing, and you go on. We get nothing. If you want our full engagement, there's got to be an intervention component. We've heard it from many people, many types of people, many types of community organizations. Number two, we can all learn and build from past work in community health, and that's why we're going to take a portion of tonight to talk about what we've done before so that we can share amongst each other and hopefully will not repeat some of the mistakes or any of the mistakes that we've made in the past. But finally, the thing that was most heartwarming to me is despite the past that may be negative and sometimes, it was clear that the community wanted to go forward with this thing, with Hopkins. They generally wanted to go forward. We also had a meeting with Hopkins faculty. Same thing. Here we are. We're thinking about doing it again. What do you think? And these were the three bullets that came that I heard from the Hopkins side. There was also significant interest for many different reasons in going forward. There was really a differing perspective on what the survey, or I'm sorry for putting that word in, what the health assessment should be. Should it be a survey and a survey alone? Should it have focus groups? Should it focus on door-to-door? Should it go to schools? Should it go to churches? There was a lot. Should it focus on social determinants and psychological and behavioral things? Or should it focus on clinical factors and clinical determinants of health? There was a real discussion there and differing opinions of what it should be. And finally, in the same way we can't fully engage the community without an intervention aspect, if this does not in some way relate to the work that our Hopkins faculty do, we will have a difficult time fully engaging them. So, but there are other lessons learned, and we asked you to share with us when you RSVP'd. So if you look in your packets, we printed out for you some of the comments that we got from you. Now, some people offered more comments than just lessons learned, but we're not going to read them all or go through them all. But maybe we'll look at one or two, and then we give you an opportunity to, if there are some others you'd like to share with us. Turn to the one that says from Dr. Bernie Geyer. Dr. Geyer is a professor here at the university, and he was involved with me and several of you here in a process several years ago that was a collaborative process between Hopkins and the community to do a health assessment. We worked almost weekly with community members, a broad range of community members from East Baltimore and West Baltimore for over 2 years, about 2 years, meeting almost every single week and defining roles, et cetera, et cetera. But that process, for a variety of reasons, did not come to fruition. We did not actually do the health assessment. And Dr. Geyer offers some of his comments from his perspective there, and I thought they were illustrative, so maybe we can read. I'll just read briefly from the first one. It says, community-based participatory research involves an enormous amount of process to build trust, develop a shared language, and work through all of the technical issues involved in reaching a shared goal. The effort is worth it, but all parties need to be aware that the perfect cannot be the enemy of the good. It cannot drive out the good. And that delays in the work plan can scuttle the entire project, which ultimately benefits nobody. We did a great job of working through all these issues, but by the time it was completed, we had missed a critical window of opportunity for funding, for institutional support, etc., and thus working through the process aspects of CBPR in a timely fashion is important. I thought that was illustrative and important. And I won't read the other ones. They're long that you can do it. But I do want to open it up to any of you if you had any thoughts about that comment or any of the other ones you wanted to highlight, or you had comments of your own, things that you have learned about doing this kind of work, either with Hopkins or with other groups that you think is particularly important to share as we go forward. If you would, because we are streaming this to the internet, please use the mic, and you can even come forward or we can bring it to you, whichever way you like. Is there anybody that would like to share a comment with us about working in community university collaborations? Dan, I know you've done a lot in this area. You want to share a comment? I'm sorry, you know. Why don't you turn around so everybody can see and tell them who you are?
Of getting data from a health survey.
Great, thanks. Were all of you able to hear what he was saying? Okay, even though we didn't have the mic. How about somebody from the community? Leon, you never bashful for speaking. Why don't you come on up and tell us what you think, your perspective.
Good evening. As a community person, I think that's how I expected Hopkins to react. Just roll it out. Don't give the community a chance to get involved. Just roll it out. That's one of the problems we've been facing for a lot of years around here. People come to this community and they say, I know what's best for them, instead of finding out what the community feels and what the community is asking for or want to be a part of. We worked 18 months with Chris and Dr. Geyer, and we diligently attended these meetings, put forth every effort to try to collaborate on an even basis, and we were lied to several times, and the process broke down. We were told in the beginning that there was money to roll this out, so we were trying to work on how the community could be assessed for the 50,000th time, but at any rate, we were going to do the assessment and show them again that the same needs are there, not very different from the many that you have beforehand. We were also going to look at ways of getting access to health care. There's no need of finding out all these problems, having people tell you constantly what the ailments are and so forth, and you don't give them no hope where there's anything that can be done about it. And one of the things that I've urged Chris to do this time to avoid running into the same problems that we ran into before is to bring the community in and openly let them be a part of the process. We didn't ask Hopkins to do everything as far as health care was concerned or access to health care. We said that had to be a part of the end solution. Didn't mean it had to come all from Hopkins. There are independent clinics in the area. There's independent health centers in the area. There's University of Maryland that'll do something, Bayview. We looked at all options, and we were ready to put them out there. But when you come in here and you say, let's roll it out and try to work things out on the back end, it's not going to work. We're really tired of it being rolled out, and then you tell us what you're going to give us at the end, just like the research. When you do research, do the same thing. You research and leave nothing in the community afterwards. And that's the wrong process. You should leave something substantial in the community after you research them. You don't even give them the benefit of knowing what the results were because you put them in a journal. How many people in this community read from a journal? You know, these are the things that's wrong. And if we're going to start this same path, I need to leave now because I won't be a part of this. But it's not going to happen where you roll it out and then tell us what you're going to do and just do it. Things are changing. I hope we can work together, but I've told Chris several times.
Don't worry about Leon. He'll speak his mind. And that, to be honest with you, I want to be honest with you. I want everybody to feel like they can speak their mind. Because if we can't do that, then we're missing a boat. We're really missing a boat. Anybody else? Anybody want to share what they've learned, what they feel? Michael? Why don't you introduce who you are, Michael, so that people know who you are?
So I'm Michael Scott. I'm a merchant banker, investment banker, venture capital type by trade, but I'm from this community. And I work with Equity Matters, which is focused on social determinants of health. It's a joint center for political and economic studies effort funded by Kellogg. But what it really means is communities are given empowerment to determine what the course of their action is post expert input. So there's a teaching process that goes on, a sharing process. And there are 20 teams across the country where the greatest health disparities exist. And then we have a mini think tank every 3 or 4 months. And essentially, it's a community-driven process. And so I mentioned the venture capital part because it seems very much to me, I know it when I see it. You have funding timelines, you got inputs, you got all kind of fancy timelines. But I think your point is well said, is that if authentic community engagement it does not exist, the data says the outcomes won't change, because the data says social determinants of health account for 70% of the excess death and disease in this community. All right, so 10 to 15% is access to care, 10 to 15% is genetics, which is not race. That leaves 70% to something. Some would have us believe it's personal responsibility. The data is clear that that's not the case. And so if you're going to be data-driven, if you're going to be best practices-driven, the best practices are clear. This isn't pie in the sky. This is NIH, CDC stuff, right? So the community needs to be at the center of that, and it needs to be social determinants-driven, period. So when you say, essentially, we can't do an economic plan, or we can't Well, you've already X'd out the 70% that causes the health impact in the community. So you have to start from the premise that we're going to follow the data. So the data says the World Health Organization says it's social determinants. NACO says it's social determinants. All the fastest growing economies in the world now say social determinants. And oh, by the way, the top of the capitalist food chain are in concert, Buffett, Gates, that inequity is what's driving this country downward. And so if that is the premise, and if the data supports that, so you have the moral case, the business case, you've got hard science and social science, the only thing left is institutional will and change. And all the people that are doing this work nationally will tell you that. Tony Iton, who's from here, will tell you that the greatest impediment to this work is bureaucrats that don't accept change as a premise model. So I think your point is well said, and I think there is a way to blend the two, but I think it's on Hopkins, the onus is on Hopkins to reverse this community perception and not speak the magic words, but reflect it with their actions. And I think that's possible.
Thank you. Ann, did you want to say something?
Hi, I'm Ann Langley. I work for the health system. And I just wanted to make one comment. I didn't hear Dean Ford say anything about authentic community participation. I didn't hear him say something positive about it or something negative about it. What I heard was we can't get too caught up in process. And I'm a big process person. I'm actually really lucky that the project I've been working on now, I was given a mentor to work with who doesn't have that problem, and that's the only way we've moved forward as quickly as we have. And I'll tell you what, community needs assessments at Hopkins and in East Baltimore have a reputation for being cut down in process. Hopkins thinks it's the community's fault. The community thinks it's Hopkins' fault. I go see people at the health department, and they roll their eyes. You people in East Baltimore are doing another assessment. And they're not making a distinction between Hopkins or the community. They're just saying, man, you guys down there, you do whatever you're doing. We think So, I mean, I just want to say, I don't think putting an emphasis on not getting too caught up in process means not having authentic community engagement. I'm assuming that the community is as capable of engaging authentically, but moving forward fairly quickly. And actually, I would think you'd be a little more nimble than Hopkins. It's a real challenge for Hopkins to move nimbly like that. But I'm glad to hear that people here at least are aware of that and are committed to trying to overcome that.
Thank you. You know, one thing that becomes clear, or several things. One is, no matter where you are, what side of your coin you're on, this is important to people. And I want, no matter how difficult it gets to talk sometimes or the challenging the issues, don't forget that we all are interested in the same goal. One of the things that came out in these lessons learned, that was, you can read it later, I won't read it, is that Bernie Guy writes about it again, but he says, you know, from a Hopkins side, from an academic side, many of the academia think that the community is so complicated, just can't deal with it. And the same thing on the community side maybe, or they think that everybody is Hopkins. One thing is true. I am not Johns Hopkins. I am one person. But the same is true for the community. There is no one group or organization that speaks for the entire community. There isn't. There are some who feel they do, and there are some at Hopkins who think they feel they speak for Hopkins too. And I say this only to say we all come to this table with agendas. And in my book, there's nothing wrong with that. Let's just be open and honest about it. Our agendas is what keeps us pushing forward. Let's not try to pretend that we don't have them. Let's not try to pretend that they're not there and pull wool over people's eyes, but let's recognize that if we're going to go forward together, It's not just going to be our agenda. We're going to have to give a little, we're going to get a little. So I have no problem with anybody having an agenda. But let's recognize it's not going to be any one person's or any one group's agenda. It will be a common agenda.
How do you reconcile that, though, with best practices? Best practices are simply best practices, right? And so if you have community groups that are connecting naturally to experts that are sharing best practices, that's what it is.
Yep.
And so one of the ways that institutions have historically divided community is, my folks go back in the civil rights movement, they have what's then known as the pocket. You pick a whole word out, and then they speak your piece for you. And but then the community, so then you have this authentic, you have someone that's a ventriloquist in dark skin saying, I represent the community, but the people in the community know that there is no authentic best practices being had. So how do you reconcile that troubling dynamic? Because that seems to me over and over again when we talk to our people from Oakland, when we talk to our people from Seattle, when we talk to people from Boston, this is part of the problem is that institutions, and I'm not saying, again, as you
I
said, it's not any
understand.
individual,
It's all right, I
but
understand.
there are institutional
Yep,
momentum, I don't know what the plural is
sure.
for momentum, but the momentum for various institutions is such that it's very difficult to break. And so how do you get past that?
You are absolutely right. That is the challenge that faces us. Actually, doing a survey is relatively simple. I'm not saying it's simple, but these are the challenges that are difficult. Let me illustrate something, though. That challenge that you bring about, well, put it this way. I have never met a community advocate that believes they're not an expert about the community. Not one. And they all got different opinions of what's in the community and what's needed by the community. It's the same thing in Hopkins. And that's what I'm saying. It's okay. You recognize it in Hopkins. Let's open our eyes and see that it's ourselves too. So we have to work together to overcome that. Together. You're going to be the expert of dealing with it in the community. Others are going to be the experts of dealing with it at Hopkins. And then we're going to come together. But it's not like this is a one-sided coin. Yes. Oh, you got the mic. Great. Hey.
Variables that we talk about how we got to this place.
Mm-hmm.
You know, the lack of trust between being a Baltimorean, being a person who actually grew up here in town and not far from this place, the disconnect between the community and the institution is commonly in the misnomer. You know, the lack of communication. What the gentleman said over here, the perception of slight. You know, we have to have some real discussions as we go forward. Not to look backwards at history for the sake of looking backwards, but so we look backwards to move forward.
Absolutely. Yep. Absolutely. Anybody else? Yes. Oh, over here. Could you pass the mic? Yeah, exactly.
Well, I'll just put in a word
Could you
for.
just tell us who your name,
Okay.
introduce yourself?
My name is Nancy Fenton, and I'm representing Episcopal Community Services. So, representing the nonprofit perspective and serving people living in East Baltimore. I don't think it's necessarily a Hopkins or community mistrust that we see among a lot of our clients, as it is just a general distrust of too much intrusion on people's lives and the concern about having outsiders come in to address very personal health issues. But just based on our experience, we find that the health needs are so complex that oftentimes, as a nonprofit, we're able to partner with one group to take care of one issue, but there are many more issues. So I think the key, one of the keys I hope that we all address as a group is being able to be nimble. That's the phrase you use. That's extremely important with transient populations, people who come and go out of programs where they could be served through community programs with different medical services.
Okay. Let's take a few more. This will not be the last time we have opportunity to discuss this. So, go ahead.
Go ahead.
Just introduce
I hate to
yourself.
have my back. My name is Sally Cherry. I serve as the team leader and board director of the Risk to Reality team for the transformation team of East Baltimore. I kind of hesitate to stand up because I'm wearing, as I heard people discussing it, I'm kind of like straddling the fence here. I'm not from Baltimore. I'm not from the Western Shore. I'm affiliated with the Centers for Disease Control. I've worked at the Baltimore City Health Department. I just finished serving as a project manager for a community-based organization. But one of the things when I came into, and I worked on an international level in third world countries, which a lot of times I look at some parts of the Baltimore and I see some of the same things I saw in Uganda and Kenya. But one of the things that stood out with me when I first came to work with the organization, which much to my regret just lost their CDC funding and has closed their doors, but the work goes on, so we pick it up with the Risk to Reality, which serves health disbursements and community. I had talked to the gentlemen earlier about the community assessment, community map, and they said we're doing the same thing. What was presented to me when I came in to the organization, one of the community association presidents pulled me aside and very directly expressed to me, we don't want you being like John Hopkins and the rest of these people who come into our community, take, get numbers, and leave. What are you going to do for us? What are you going to do with us? And that was the key thing. They expressed, a lot of times people come in and they tell us what they're going to do for us, not with us. And I heard you mention data. I'm a medical technologist by profession, and I'm a computer geek. I love data, but in needs assessment and coming from I'm a clinical person. I work in sexual transmitted. I serve as a lab consultant for Centers of Disease Control, the Region 3 STD HIV Prevention Training Center. Data is important to me, but outcome is key. And whether you know it or not, CDC's new buzzword is outcome and referrals. If assessment being done, there has to be a component in there. Where is this going to lead to? How are we going to get the bottom line is, and when I do my training, the bottom line is quality care for the residents, quality care for the people. So we can do the assessment. Assessment's fine. But the bottom line, the ultimate goal is how are we going to use this assessment to get quality care in this community who's very willing to work with you. The transformation team is a group of stakeholders from all arenas, business, churches, communities, schools, health components. The state health department will be coming here because they're one of our partners. They're very active. They have a faith-based component. I talked to Heather at the state. Told I'm going over to a community assessment meeting. She said, tell me about it. So it's going to be interesting on that. But the whole idea is we can just get past ourselves. That's the bottom line. I went to a funeral Saturday morning. One of Baltimore's longest living HIV positive individuals and warriors. That says, this discussion, I tell people titles do not, I could care less about titles. The bottom line is Baltimore City, the state of Maryland is hurting. We got to get the assessment going and see how we can use the information, working with the community to serve the community. The only way you can serve the community is serve with the community. And I'm a resident of Harford County. But When I came to Baltimore, I came to Morgan State, so I got a little connected to East Baltimore. But I brought in, we have had groups come in from Harford County, Baltimore County, Cecil County. We came in clean up the streets for Surf Fest, and back in April. We had some of our doctors from Harford County. We had a couple of our bank presidents came in. They could care less. The bottom line was serving the people in East Baltimore, serving beside them, because they were out there picking up with us. And that's the bottom line for the assessment. I get a little emotional about that because I get caught up when people, okay, let's this. Okay, get out, take the boxes off the shelf. How are we going to serve with the citizens of East Baltimore? Because the bottom line, we've already talked to the mayor. East Baltimore is just the first key. We've already talked to individuals in West Baltimore. We want to, how are we going to serve Baltimore? Then how are we going to serve Maryland? Then how are we going to serve the East Coast? Because we do not have time for the health care to be in the condition of a third world country, which is on its way there in some pockets of our state. And that is totally unacceptable.
Thank you. We'll just take a few more. But I think one thing she said is very important. She does not live in East Baltimore. Some in this room would argue she has no place in this discussion. She's not from the community. My perspective, if you live in East Baltimore or any community, if you work in the community or you care about the community, you are part of the community. And anybody who cares about this community has the right to speak their mind about what they believe, whether you're at Hopkins or not, or Hartford County. You would be amazed what this lady does in the community of East Baltimore, driving all the way from Hartford County every single day. All right, let's see, where's the mic?
Got it.
Victor.
So I'm Victor Urrutia. I'm a stroke neurologist here at Hopkins, and I listened with a lot of interest the discussion and all the opinions. As we're all aware, there's a lot of baggage. But I even with the risk of sounding a little bit naive, I just wanted to put maybe a new idea or perhaps offer looking at all ideas in a new way. I participated at a health disparity summit put out by the American Heart Association last week, and actually 2 weeks ago. And one of the discussions was exactly what we're seeing here. How do you go out to the community and do research and make that connection with the community in the way that they participate, you participate, everybody benefits. And what I've been thinking, and again, this may also be part of Hopkins being so big, is that here we have groups at Hopkins that are already providing some services. There are programs that are in place, and then there's other groups that are doing research. And perhaps one way of approaching this better is to do a more integrated effort where we are providing service and doing the research at the same time, and that may help bring about that trust that we need in the community, and everybody can benefit. And I say that because the people doing the service and the people doing the research are not necessarily the same people. And we often don't interact with each other, and maybe we should, and maybe that will help put a different face of Hopkins and out there and allow us to collaborate better with our community partners.
Thanks, Victor. If I would, I want to hold that, because we're going to come back to that idea. I don't know if you understood, but his idea was somehow to provide services at the same time as we're doing an assessment. And we're going to come back to that very point. Let's take two more people, and then I can't see where the mic is. Oh, there it is. Go right. Stand up and introduce yourself.
My name is Isaac Megbolugbe, and I'm one of the faculty in Carey Business School here at Hopkins. In just listening to the conversation, since the beginning of this session, I'd like to make a very brief comment, again, for the risk of sounding naive. is that one thing that struck me is that um, working with the community is not a new idea. There's a tremendous amount of literature which many of us have been involved in also producing for over 20 or 30 years. And then working with communities in the U.S., there's a tremendous amount of expertise and knowledge of what works and what doesn't work. Mr. Scott was mentioning about best practices, benchmarks. And I think what I'm a little bit afraid of is that, or to caution, is that we do not let the substantive focus on health, in some sense, undermine the integrity of the expertise and the efficiencies that already exist in literature and the professional practice. Okay, there are people who know how to work with community very well, no matter what it is. My experience, for instance, in the areas of community development is in the areas of housing, okay? And it's not only in the US, it's also that in the third world, and especially the emerging markets, that tremendous amount of practice of what works in these areas, okay? So, so I'm just saying is that the opportunity exists here to transcend whatever might be the baggage of the past. I think the hope and my expectation, what I'm looking for, what I'm here, is to have an opportunity to essentially de-emphasize the health substantive focus and allow the collaborative framework and a lot of the things that we know that actually works in terms of delivering services and improving how a particular community functions to come to the surface. Okay, because to me, yes, the interest here is directed at health, but working with community, you can do it well, you can do it poorly, and it could be disastrous. But it's not just a process thing, but I think what I'm trying to get across is that, as many of you know, there's a practice here that in some sense, it sounds more like Chris, like surgery. I mean, either a good surgeon or you're a bad surgeon. But surgeon is not a mystery, it's not a myth. Okay, and so, I think we should be cautious and not allow the interest and the passion we have for health to contaminate bringing to the table some of the best practices, some of the benchmarks that seems to be critical to the success of this effort, which is how do we work with community, how do you collaborate, okay? And in some sense, like the gentleman just said, how can you integrate both research, okay, and providing services, contemporaneously, that in some sense makes the partnership a lot much more vibrant and a lot much more impactful that will motivate many of us. So the dwelling on the past, I think, was supposed to be a reference to just note, okay, this is what happened, let make the mistakes, but it seems to be, in a sense, dominating the conversation going forward. Thank you.
Thank you. I mean, I agree. He's saying that we have an opportunity to transcend the past. Absolutely, and that is my hope and desire. And this will be our last comment. Having said that, we can't ignore the past either. And oftentimes, community members say we want to gloss over the past. So I felt it was important to talk about it, freely and openly. We can't solve all the problems. Matter of fact, we can't solve any of the problems of the past. But by informing ourselves of them, talking about them, it helps us move forward. This is not where we're going to stay tonight or in the past, but we need to make it a part of our dialogue, or else we can't move forward. Everybody can't move forward effectively.
Good evening. My
stand
name
up,
is
just tell us who you are.
My name is Jamal Mubdi Bey. I'm the Director of Community Outreach at Sojourner Douglas College. And I think a big source of frustration for the community, at least is, especially with assessments, another assessment, is that it's like so much of the energies that we expend in our society, it looks at symptoms and leaves underlying causes intact. I'd like to just read a short excerpt from the comments that I put online. I said that
Everybody has his comments in your packet.
yes.
So you can,
Yes.
if you'd like
Short
to follow
excerpt.
along with him.
In the area of urban health, do we design a system capable of supplying the resources and services to address the unmet medical needs of an urban population, or do we support in that population the capacity to transcend its dependence and find its own path to health and wellness? For instance, the Urban Health Institute might succeed beyond everyone's expectations in satisfying the community's expression of need, yet in so doing, ultimately fail by leaving people still dependent upon an entity other than themselves. So underlying all these issues, including the health disparities, is the issue of poverty. And after the assessment is done and some institutional response is designed, what will it avail in terms of, I mean, people will continue to be dependent on that institutional intervention rather than having the capability to address their own needs. So, I think that this is a pattern that our society is sort of locked in, dealing with symptoms rather than underlying root causes. That's my comment.
Thank you. We've heard several people tonight having differing views, all knowledgeable about their areas, passionate about their areas, interested in their areas. But it illustrates the challenge that is still before us. We are not going to be able to do 100 health assessments or even 2 health assessments. There's going to be one. We don't have unlimited resources to fix everything that actually needs to be fixed or research everything that needs to be researched, yet we all believe that it's important to do something. The challenge is, as a group, to decide what's in and what's out. We can do it that way, or, as many of you have implied and stated, the way that it's done has been done often in the past, that somebody else decides for you. I'm committed that this process will be successful, will be high quality, and will be the result of a truly collaborative process. It will not be easy. You will not agree with everything. But it will be something that, if we work together, you will hopefully see as valuable, not just to somebody else, but to you as well. And it will have been worth whatever process, whatever time, whatever aggravation, whatever joy it may take to get us there. But we do have to get there, and we're not going to get there if we just talk about these good and hard and difficult issues. We have to lay out some path, some way of getting where we collectively want to be. And we can do that 2 ways. We can stay and talk about where we want to begin and how we want to do that, and that's one way to do it. Or we can start with an idea and then decide how we like it or don't like it and how we want to change it. The first method takes a very long time. It's a good method, but it takes a very long time. That's the method we used the last time that Leon and others were a part. We didn't have a deadline on the end, as somebody brought out. This time, because the Urban Health Institute has dedicated some resources to this, they have a timeline. There is a timeline. There is an end goal. There is a product that we need to develop. So what I have done, knowing most of you in here and having worked with most of you in here, I did some thinking to put together an idea as a starting point, not to say this is what we will do or we won't do something else, but as a starting point, as a roadmap of how we get, as a process of how we get from here where we are today, just talking about ideas, to where we want to be in a year from now with a solid product, plan, and product in our hands. So what I'd like to do for the next 15 minutes is just tell you what I've been thinking about, and then we will discuss it briefly and move forward and close out after that. I think you'll see what I mean. So if you do have questions, please write them down, and then there'll be ample opportunity. But let me just get through the whole thing, and then we can talk about any part of it. Feel free, again, to get yourself anything to eat or drink as we go forward. So I fundamentally believe, and some of you have already articulated in emails that you've sent me and things that you've said, that in order to work effectively together, there are some things we have to agree on from the starting point. I've put down 5 that I think are critical. The first one is civil dialogue. We have to agree amongst ourselves that as passionate as we are about some of these things, that we will not allow ourselves to degenerate into back and forth and personal attacks on each other. We are all passionate and believe strongly in what we believe. As I mentioned earlier, there is no community person that doesn't believe that they're an expert on something. And everyone knows there is no Hopkins person that doesn't believe they're an expert on something. Okay? So we're a room full of experts. We still have to come up with one plan. And the only way we're going to do it effectively is if we agree, we will keep it civil. We will speak to each other respectfully without personal attacks, without passive aggressiveness and any other form of that sort of thing. 2, open communication. Some people were a little uncomfortable with some of the things that were said tonight, but I think it was important. We must have a process where everyone feels that their review is respected as an individual. It is not just the Hopkins experts that have respect and community, or vice versa. It's not that we beat up Hopkins because they were part of the process in the past, a problem in the past. And everybody at the table now must feel free and open to express their opinions. And my goal is to put in place a process that facilitates, that enables everybody to have that opportunity. We won't be sitting at groups like this, because if we do it that way, we'll never get anything done. But there will be ways that if you really want to be a part of this process, if you want to participate, you can. And you must feel free to do so. It must be transparent. No backdoor dealings. Nothing is going to be decided outside of you. I can't control what any one of you do. Some of you may leave here tomorrow and then start talking about what you want to get me to do or get somebody else to do. I can't control that. I can guarantee you that I will not do that. I will not engage in that, and I charge you, I encourage you, implore you not to engage in that kind of thing. We can decide together what it is that we will ultimately do for ourselves. It won't be easy. It must be transparent. 100% total engagement. Talking will not be enough. Coming to meetings like this and giving us your opinion and going home and then criticizing it when it's not what you want will not be enough. If you are committed to this process, if you love that East Baltimore the way you say you do, if you're committed to making it better the way you say you are, I am imploring you to remain engaged. And we will put in place, we hope to put in place a process that shows you how you can be engaged beyond just talking about it. And finally, accountability. If you're engaged, and if you say, we say we're going to do something, we're going to be looking for you to do that and hold you accountable. That's on the Hopkins side. If we agree to some services being offered, they need to be offered. Some money being put on the table, it needs to be. But it's also on the community side. If you say you do X, Y, and Z, your organization does X, Y, and Z, and we find a need for that, we're going to come to you and we're going to expect you to do it. What's good for the goose is good for the gander. I believe fundamentally that that's the only way. With these five, there may be others, but at least as a minimum, these five things are critical if you're going to have truly collaborative processes. Truly collaborative processes. And so I'm committed to making sure that this process, to the extent that I can have any influence over it, is based in these five things. So we need a project title that describes this. I did some thinking. This is what I came up with. You might like it, you might hate it. But this is an idea I have. Building a healthier East Baltimore together. Because for me, it illustrates what I think we're saying we're trying to do. A healthier East Baltimore will not come because the federal government makes it an empowerment zone and dumps $100 million there. It's not going to come if Jeffrey Canada brings his Harlem Children's Zone down here and we all of a sudden do that. It's only going to come if we build it, if we work at it, if we do what needs to be done. It's the only way it's going to come. And it's not going to, one building block at a time, and it's going to come, it's going to come if we do it together. Sure, you don't have to be a part of this process. You can continue doing what you were doing and do good work, whether on the Hopkins side or on the community side. But I submit to you today, we will be able to do more together than you will ever be able to do by yourself, no matter how good it is. And so, this process must be done together. We can talk about later if that's the name or not, but this is just an idea. This is just a straw man, some thoughts that I've had about what we're doing and what we're trying to do. In terms of the timeline, Bob Blum, the director of the Institute, has asked that we be ready to do whatever we're going to do by the end of next summer. So we essentially have just under 13 months from today to plan, to decide together, to plan, to pilot, to test, to do whatever, to train, to do whatever it is we need to do that we decide we're going to do in order to be ready to do it October 1st next year. That may sound like a lot of time to some of you, but it's not. It will go by much faster than we all would like. And this is one of the things that distinguishes us from the last effort and other efforts that don't have a back end. We've got a back end here. We have a window. We have a window of time. And already, because of that window of time, because of this idea, you're interested, but I've already heard about potential funders who are interested in funding parts of this. But if we miss the window, if we're not able to come together, if we're not able to decide together what it is we're going to do, we may have the same fate that we've had before. Organization and leadership. This always can be a difficult discussion, and we all know why, because of all these things that we have been talking about. What I would like to suggest to you today is that we use a process where, I'm sorry, I thought there was a pointer. So, where we have what we call a Community Hopkins Advisory Board. Who is that? That's you. This is where the decisions are made. This group. Not by some small group in a back room of Hopkins, not by some CBO all by themselves in the community. This group. So if you're committed, if you're engaged, you will be the decision maker of this group, the control point of this group. But we can't effectively work as a big group like this. You can't get anything done. So how do we actually get the work done? I submit to you today that we will organize this process of planning around a series of planning teams. Each one of you, and others if they wish, forming teams that will, your task, your goal will be to propose what we ought to do as a group for whatever part of the thing you're working on. It might be the methods. It might be student involvement. It might be community involvement. Whichever group you want to be a part of, you're a part of that group. Each group will have community members on it and Hopkins members on it. Each group. It will be your charge to come together. We will be staffing it. The Urban Health Institute will support it. And your charge to come up with a proposal to then submit to this group, for which we then input and decide, and then finally refine, and then be ready to test and go forward next year. And I said it's in this circle of the UHI because the UHI has committed to support this process. And I can tell you a little bit more about that, about how we can do that. So let me tell you about the teams I proposed that we had. There may be need for others. You can tell me what you think. But the first one, we got to have some people thinking about what are we going to do specifically. The charge for this team will be to propose to us, on behalf of us, what's the conceptual framework? I mean, we talked about many things tonight. We talked about social determinants of health. We talked about economic development. We talked about health services. We talked about, behavioral problems. We got to decide somewhere. We cannot do all of those things. We have to decide. This group will think about what portions, which one, or if it's all of those in pieces, that we should try to address, and then provide that to us, for which we then decide if we'll go with it. Study hypotheses and research questions, sampling frames. There's been talk offline of, should this be a door-to-door survey like many other surveys have done, or should we go into schools? Some people are very vocal to me about how we need to attack churches, not homes, not door-to-door. We need to have focus groups, not even door-to-door survey. Well, we need some people thinking about that, and these things are related, and that's why I put them all in the same group. And already some of you have expressed an interest to me in being on some of these groups, and we will have a sign-up list here for any of you who wish to be a part of any of these groups, to be a part of these groups, or you can always email us at any time. But that's the methods team. It's not working. There we go. One of the things I think is critical that it's not just a bunch of Hopkins people doing it. Students and community members must be involved. Actually, interestingly, some of you might be surprised, when we had the meeting with Hopkins folk at the beginning of the summer, some Hopkins folk came up to me and were very excited about the possibility of involving students in this process. Not just to do it, but as a very worthwhile part of their training while they're being here. I think that's absolutely right. But what specifically should they do? How should they be trained? What should they be trained about? Same token, how can we involve community members? Do community members need to be trained on something? Who's going to do that? Do community members need to train Hopkins on some things? What are those things, and who's going to do it? Because, yeah, I do believe there are some things we ought to have community members training every person that's going door to door or going whatever we decide to do. That's what this team is going to be thinking through and trying to propose for us, for you to decide on. How do we oversee that process? We got people here, Mindy and others, who work with student groups, and we're looking for you to help work that. And how do you manage it? It's a complicated issue. We got nursing students, we got medical students, we've got public health students, we got undergrad students, we got students in the community. Think it through. We can't think about all these things in a group like this. We'll never get anywhere, but a smaller group can start. Emergency intervention and response team, and I know the Hopkins people are just jumping through their limbs right now, but I heard, and I actually agree. One person at the community meeting that we had early in the summer said, we've been researched enough. We may not know everything, but we know enough to do something. I actually agree. And I agree also with Victor, and the idea that I have is this. We can't fix and intervene on everything in the community because we don't have endless money. We don't have everything. But if we go door to door, if we have focus groups, we are going to come in contact with some emergencies. Pure and simple, bona fide emergencies. We're going to. I do not believe that it's enough to provide that person with a phone number to the emergency room or to somewhere else and say, give it a call and that's how you do. But what this group could do is to sit down ahead of time to say, okay, what are emergency? Actually, the other thing is there are actually a lot of resources already in the community to handle emergencies. We heard about one at the community meeting where Baltimore Substance Abuse Systems, run out of the health department, has put together a new program for anybody who is having serious mental health issues, suicidal, psychosis. Anytime, day or night, no matter where they live, a hotline, not a hotline that calls and then we'll talk you through it, a hotline will come to your house and we will put you in treatment immediately. We ought to have a system. And so that's something that we might be able to help address if we come across that emergency, and it doesn't cost us one solid dime. Not one solid dime. There are other programs out there. There are the answer to this emergency is not send them to Johns Hopkins Hospital or Johns Hopkins ER. It may be that we come up on a door, it looks like somebody's there, but it's an abandonmenium. You know what that is, don't you? I got to interpret for the Hopkins folk. You know, that's a place that's abandoned, but somebody's living inside because they can't afford anything else. And it's a pregnant mom, and she has no place to stay, and the roof is coming inside. And you, Joe community-based organizations say you find places for people to stay, well, then we're going to bring that person to you, and 100% accountability, we're going to be looking for you to find that person a place to stay. But we can't handle everything. This group will think about which ones are the ones we should and we can address, and which ones are the ones that we just can't for whatever reason. And what's the process of doing it? What's the process of making sure it's safe, it's accountable, it's everything, it's legal. And legal perspective might be very well important. We might want to do some things, but legally we can't. So we're looking for people to get on this team so that by the time we actually do this survey, we will know ahead of time what emergencies we are going to handle. We will have chosen together how they're going to be handled. We will have trained the appropriate people who are going to be handling those if they need training, and we will be ready to handle them when they come, not just to address them, but to resolve them. Doing something. I heard it loud and clear from the community. We need to do something. And I think it's reasonable for some things. Community relations, communications and communication. It strikes me that one of the problems with these kinds of things over time is that even with good intentions, we don't communicate well or effectively amongst each other. It happens even at Hopkins. What the Cancer Center is doing, we don't know, and what this one is doing. We need to have a robust, multiple ways to communicate with people. I'm thinking old school and new school, newsletters, print, email, Facebook, YouTube, everything, any way that somebody can communicate with us, they ought to be able to communicate with us. And it's not limited to those who can come to a meeting. We did this in the evening today because we heard last time that 6 different ways, yes. We're going to do whatever we need to do that. 6 different ways. And we heard that it's hard for people to come during the day, so we did it in the evening. But you know, some people can't come in the evening. That's why we're streaming it live right now. But some people don't have internet, so we need something else for those people. We're going to have, hopefully, a way so that anybody wants to be involved, even if you can't come to the meeting. I heard from Hopkins folk, they just can't. They want to. We understand. We got to have a way so that you can have meaningful input, but you don't have to spend hours all the time in meetings like this to help affect the change that we're working for. Need to think it through. This group, this team will think through that whole piece of it. And some of you have already expressed an interest and a willingness to be on this team. And then finally, funding and sustainability team. Now, I know that's the tough one, and right now it's only me on that team. But that's actually all right, because I actually feel very good about this. I actually do believe that if we're able to accomplish this, I will not have problem. I will be able to find the money that we need to find in order to fund this. Just to give you, just to tell you a little bit of my thinking there, is that I'm not looking to Johns Hopkins to just give us $1 million or $2 million. That's kind of the approach that we had last time, and we didn't really have a real plan for it. And it obviously it didn't go over too well. But we're going to have a real plan this time about how we're going to use the money. But I don't think it's wise to just look at one place. We're going to be looking, we're going to be looking at Hopkins, yes, to provide, but we're going to be looking, anybody, when I talk about total engagement, that means anybody who wants to participate in any level. If you're, Joe, community person, you want to give $5 to this effort, we're going to have a way that we'll be able to get that from you. So there's going to be some goals that we're going to set for Hopkins, to raise from Hopkins, but there's also going to be goals that we're going to set for the community. There are some people that say, oh, it's a low-income community, there's no money out there. That may be true, but I tell you what, some folk driving better cars than the one I drive. So there is money. It's a question of where do we want to spend it. And if you're as serious as you say you are about this community, as the old saying say, let's put our money where our mouths is, on the Hopkins side, as well as on the community side, as well as the foundations. We're going to be going to foundations. I've actually already heard from a foundation that is extremely interested about this. Didn't even have to go after them. They came to me. So I really believe, I may be wrong, we will all know in 1 year if we fail or if we succeed. But I believe that if we are able to do it this way, we will be able to find the money that we could not find last time to do this process. We can talk more about that later. So what do you get out of this? That's the bottom line. I can't tell you what's going to happen at the end of the day. Talk about, are we going to put more clinics in the community? I can't guarantee any of that, and I won't even begin to try. But here are some things that I think that we can reliably get. Number one, if we do this, it will be a new model, I believe, in some ways, not totally different, but some ways very new, of doing collaborative research at a place like this that can be exported to other places. You will be part of developing a new model. Number two, there will be people in the community who will be trained in marketable skills. That will stay with you no matter what happens. You will be trained. There will be some of you doing training. So you will benefit financially from that. That's a real tangible. We will obtain critical health information. That's what everybody talks about. If we're lucky, we may begin to improve. Begin to improve. Begin. This will not fix everything, but maybe we will begin. And we're not the only ones doing this kind of stuff. So maybe we will begin to improve community perceptions of Hopkins and begin to improve Hopkins' perceptions of the community. We will facilitate productive future health. If we're successful, I have no doubt this will lead to many other things that will be beneficial for all of us, where all of us can get involved, which will lead to economic development. It'll lead to community development. It'll lead to a whole bunch of things. And finally, the data. Everybody wants to know who's going to own it. You stay involved, you will own it. I've talked with Bob Blum about this and said, this is my passion, and he agrees that those who remain involved will have preferential access to that data for a 1 year period. Those who are not involved will not be able to get that data at least for 1 year. After that, we will make it into a public use data file for those who wish to get it. So if you want data, you want this data, and you stay involved, you will have access to the full or partial data set that you would like to have. I've not heard of that in other places. Maybe it's there, but I have not heard of that. These are my thoughts about how we get from A to Z, about how it is possible to accomplish something that's different, but's doable in a year. Will not be easy. but we can do it together. I'd be happy to take any questions people may have. Steve?
Chris, I actually just want to have one comment. I don't have a I have a comment and actually a challenge for the group. One of the things that I will ask that we do is that we develop a feedback loop so that we become a learning organization uh, within the community and in Hopkins. We have to become circular.
Well, I see that as part of that communication strategy. That's, evaluating and letting people know what we're doing on all sides of the coin is robust in the community. It's robust at Hopkins. The journals are for Hopkins. It's something else for the community. So I agree with you on that. I'm sorry.
Hey, Chris, I didn't think that was a bad list. There, well, there's one thing missing in that, for me, that determines whether it's a good list or a bad list, and that's equity. We talked about agenda, so you all can be clear what mine is from today on. I will always, every time you see me, talk about equity. It has best practices. It is clear who the honest brokers are, some of whom come from Hopkins that we can all agree on. Tony Iton, I mentioned. Kamara Jones, I mentioned, who was just here last few weeks ago. So a commitment to equity, though, changes some of the dynamics of what you had on there in terms of perceptions in the community. It also dramatically changes the research title, right? Because the healthy community includes the greatest impact on that community, which is Hopkins itself. So my question is, it's not just does the community get to train Hopkins, but does the community assess Hopkins? Does it get to assess the commitment that Hopkins has in terms of equity? Do we get to have the community have an assessment of Hopkins in terms of its commitment to equity vis-a-vis other institutions of comparable import? Because I think that is an important.
I would agree. We will decide what gets evaluated and who gets evaluated, and your being a part of the process will ensure that view is heard for sure. Anybody else?
Good evening, everyone. One area I didn't see was the legislative, and I feel that public policy dictates a lot of what we can and cannot do in this assessment. So I think we really need to analyze some of the public policy that focuses on some of the issues we're addressing and implement a team to research and work with the legislative.
So again, there are some things I either don't have the expertise or couldn't see how we could fit in, but with that, it sounds like you might be a good person for the methods team to think this through. And if we can come up with a way that it's doable and there's agreement on doing it, we should do it. It's up to us to decide. It's not for me to decide. We will decide, but that will only happen, it'll only get discussed if you're a part of the group that's thinking about those things. So I encourage you to be a part of that group.
Chris, the layout that you had was pretty comprehensive. I was wondering why that wasn't printed with the other documents that we got.
So a couple of reasons. I'm gonna be honest with you. I was afraid it was gonna scare away some of you. Be frank. Some Hopkins people, and some parts of it on community side. And I wanted to at least get the opportunity to say it. You may still leave, you may still decide to disengage, but at least you will have heard.
Well, I don't know if that would chase them away. I think the fact that
Well, it was both sides. It was not just Hopkins. It was there was something, as I said, there were some things in there that I think the community might have a rough time with, but there are certainly some that Hopkins would too. And again, it may change. These are just a starting point for discussion.
Okay.
But that was really part of my rationale for not printing it.
All right. The question I have is this. The last time, and I'm going back to this because I don't want us to fall into the same pitfalls we fell into before. The last time, the upper echelon of Hopkins had a real problem with many of the things that we came up with. The fact that we had co-investigators, you and Glenn Ross as not you leading and him following or Hopkins leading and the community following, but the two of you working in tandem to push the initiative forward. When you had to go meet with Hopkins and he couldn't go, and but you could come to the community side, it was a real problem. And you know, if Hopkins, up echelon, the president and so forth, are on board with this, then I'm coming here and sit down with us and let us talk all across the board and let us discuss it openly and see their buy-in. The legislative process was something I had mentioned before. It's important. You don't have to seek funding by yourself. There are people that were elected by the people from these communities. And this is a way of putting onus on them to do what they should do. So it's not just a crisp battle to get funding. There are a lot of foundations that if you show them this clear-cut, true collaboration, they will be really anxious to be one of the first to step out and say that Hopkins really engaged in a true collaboration, openly, transparently, as you put it. And, you know, there's some other things that I saw that could have been added to your piece. That's why I was wondering why you didn't have it written, so I could have just added them in as we went along. But I'm going to try to get a copy from the young lady here who typed them up.
We'll send it out to all of you now that we've talked about it. And two, you always can send emails or call us on the phone. Ariel Sloan. Ariel, where are you? Raise your hand. This is Ariel. She's the project manager for the project. You can send an email to her and I get them. But this is, again, I don't want you to see this as the meeting for decisions. This is an open process. It will continue as you want to continue to be involved. So there are many, many ways to be involved in this process. Let me just say two things in response. You're right, Leon. There were some challenges before, and that's part of my thinking as to how I got here, to avoid some of those things. This time, it's a much more collaborative process, not dependent on any one group at all, but all of us. But as for the leadership, there actually is somebody here tonight who is in the leadership of Hopkins. And I don't know if you want to say a few words, Andy, or would you be willing to say a few words? Andy Frank is actually the special assistant, I believe I'm getting your title right, you can tell me if I'm wrong, to President Daniels. And when we told him about this, what we were trying to do with, I can't tell you, it's almost like I hit the button to send the email and he responded that he's interested in this and he wanted to be here. Did you want to say a few words, Andy? Why don't you use the mic so everybody can hear you?
You get back to your desktop, you have about 5 more emails. I've been shooting them off as we've been going on. I've only been here 8 weeks, so I'm in no position to comment. Only I'm here really to listen, to understand the history and the opportunities ahead. So I do bring an interest from President Daniels' office. My job description is really literally on my card, special advisor to the President on economic development. And economic development is sort of broadly defined and needs to be, to include things that you typically think about in job creation, wealth creation, inclusion, but also public health and a more holistic approach to building community. So I'm very much really looking forward to participating in this process and really learning from the community and from Hopkins about how these things happen, and to the degree that I can bring support from the President's office when necessary.
Thanks. Anybody else? Thoughts, comments? And again, you don't have to. If you think of it tomorrow, email me tomorrow, talk to me tomorrow. A couple more, and then I'll tell you how we'll go forward and we'll close. Victor?
So I just had one thought. I thought your presentation was great, and but in the project outcomes, I think it would be wise to put improve the health of the community as an outcome.
I'm sorry, I couldn't.
Improve the health of the community as an outcome.
As an outcome.
Yeah.
So I can just tell you my thinking. My thinking was, you know, you're doing an assessment, so that's assessing things. That's not actually doing things. That's why I actually think it is important to do some things. But if we're doing, you know, hitting emergencies, I'm not sure what effect that can have in terms of improving the health of
Well, the reason I'm just going back to what I mentioned before, doing at the same time that we're
Yeah,
assessing.
more broadly than I
And
suggested.
actually,
Okay.
I was thinking that the Emergency Response Committee should be probably renamed Emergency Response and Intervention Team, which
Actually, that's what I had. I didn't
well,
write
no,
it, though. You're
well,
right.
it's the words are kind of changed, the commas are
Okay.
in different places,
Sorry.
but it basically the idea that it's not just emergencies, but intervention at the same
Yep.
time,
Yep. And
ongoing and sustained.
And let me say, again, that team, if that's what you want and we can figure out a way to do it, we should do it. It's what the group decides, and we can fund it, we should do it. So I'm all for it. Anybody else? Dan?
I just say that I think what we should probably, I mean, data for data's sake is not particularly interesting or motivating to keep people through the hard, barriers that you'll see along the way with it. So, and part of the study hypothesis is to come up with some decisions. What are 3 or 4 decisions that the community with Johns Hopkins need to make about should we go path A or path B to try to improve the health of the community, and then make sure that the data that you get are going to help you make that decision. Because I think that's, part of that is there, I mean, you have research hypotheses or research questions, but I really, at least for the first phase, has to be more than that. It has to be more what help us make some decisions that on which pathways to go.
Yeah, no, I agree. This is, it was easy to sort of talk about these groups. It's not easy to do what these groups have to do. And Dan is absolutely right. But at the core, we can't do it effectively in a big group like this. And that's why I said, at least even if that group decides those things, then we can share it with each other and decide. But it's just not efficient use of anybody's time to try to decide those difficult things in a group like this. I agree with you. Anybody else? Brian, in the back?
So I'm Brian Gibbs, School of Medicine. I'm wondering, Chris, about leadership. And I know that you drew the circle and outlined the advisory group. And then UHI was at the bottom. So I don't know in terms of making decisions, setting agenda, and sort of co-piloting alongside you, whether there will be a equally empowered entity or individual who will balance the leadership that you bring and the representation from the UHI.
Let me be very frank and honest with you. The reason that we have come to the point in research where we need, at times, that kind of leadership is because too often in the past, the leadership has been unbalanced, has not represented the perspectives of those involved, particularly the community side of the coin. And so from that history has emerged this model, this ideal, that as one step in getting towards a shared perspective or shared ownership and shared responsibility, that there is somebody from the community who is in all levels the co-leader. That is actually precisely the model that we used in this former attempt at an assessment several years ago that Leon was referring to. I think it has both positives and negatives. The positive is that it puts somebody from the community at that level. Everybody can see it, it's vocal, it is a sign of that balance or that, that level playing field, which has been far too often lacking and is a major source of problems on the side of the community. The challenge that we experienced during that time, there were many, but one is in order to do it, now this may be because I was not an effective counterpart to Glenn. I'm willing to accept that if that's the case. But this is the reality, that having that person involved became a managerial and logistical nightmare that slowed the process down excruciatingly. Let me show you and tell you how and why. What it meant out of good faith, out of a desire to do exactly what you're saying needs to be done, and I recognize needs to be done, it meant that every single, not only decision, but every single communication, every single piece of paper, every single email, every single thing that went out to anybody, anywhere about this had to be done from me or from the leadership, whatever, had to be done in duplicate, which meant that we had to coordinate between two people who were already busy enough in and of themselves, which meant that it was an entire process just to even get a sign off, and it was an amazing nightmare that slowed the process down. Now, we didn't have a deadline, as I brought up before, so we were able to do that, and it was valuable. I do not personally believe that we can't, I am not the best person to use that leadership style and accomplish what I think we need to accomplish in the time frame that we have to accomplish it. And so I am suggesting that we do not use that this time. I know some of you think that's surprising, but that is what because here's the other side of the coin. What you really want, it is possible to have somebody in that position and still be out of the loop. So it's not really the position you're interested in. You're interested in the equity. You're interested in the voices being heard. You're interested in several things. And it may also be the position itself. It may also be.
Well, Chris.
Let me finish, please. Let me finish. You'll have an opportunity.
You running on. Come on.
So, having said that, this is what I will say. Because I have not, since that time and now, gotten to the point where I think I can effectively manage that effectively and accomplish what needs to accomplish in the time period that we have, I am willing, at this point right now, if there is someone else that can do that and is willing to take the helm of this project and lead it with a co-person or, and that means the planning process, the funding process, and the implementation process. I am willing at this time to sit down, allow that person to take the lead, and then I will support that person in the way that I think that I'm asking that the person support the leadership that I'm going to have, so that everybody's voice is heard and that everybody's views are heard, but we have a management style that some people have talked about is nimble enough to move forward, to make the decisions that need to be made, not arbitrarily, but so that we can accomplish the goal that we have. If there is such a person, I'm willing to sit down right now.
Am I allowed to talk now?
What? No, not yet. And I'm asking, if there is one, Brian?
I don't think that that's the right question, though I think that's getting us in the right direction. I think to ask of a person in that role out of this group that basically has a whole different agenda for being here than, a full-time job in doing that it may not be a person, but it may be a compilation of groups or individuals that will serve as that counterpart. And I appreciate everything that you said. And the one challenge is blending agenda, because your agenda is based on a timeline that is a deliverable at the end of the year. The community's goal is to deliver a product that is efficacious, really, truly beneficial to their needs. And it may not be able to be delivered in that time frame and be as inclusive as possible, but you, in driving that, we want to come as close to that timeline as possible. So we're operating with different metrics, and we just kind of have to put them on the table. Or if the metric is superimposed, then we don't know whether it's a realistic metric or not. And it could very well be. I don't want to go too far with that inference, but we just kind of want to be a little bit more deliberate, I would
And
suggest.
I'm entirely in favor of that. We do have, it's not just me wanting to do it in a year. This is what the Urban Health Institute has said they will support. So, and again, this can be done outside of the Urban Health Institute, it can be done outside of Hopkins. But for the opportunity that we have here, and that's why I did say we all have agendas and we need to put them all on the table. And I've tried to be as open about mine as I've encouraged you to be open about yours. This is part of the opportunity that we do have now. And if it's not possible, then that's a decision point that we don't even need to get started if we don't think we can do this in that time period. Having said that, I'm willing to discuss this, and I am willing to think about ways that we can do this that helps get to where we all want to be. And I don't know, and I'm being honest, I don't know how, what I don't want to happen is that we take 6 months deciding this. Because that's part of what happened last time. Because these are difficult issues, and we want to get everybody where we think it is. And so what I'm suggesting today is we don't have that liberty this time with this opportunity. We can decide to use a different opportunity. We can decide not to do it. I'm willing to discuss, but I think if we take 6 months to decide or 3 months to decide, we jeopardize our ability to effectively complete this opportunity. And this is why I have suggested this. For those of you who know me, who have worked with me, I think, correct me if I'm wrong, I'm sure you will, that your voice will be heard. I will ensure that. Your voice will be accounted. This will not be a Chris deciding. So for those who don't know me, at this point you can either choose to believe or not. But it allows us an opportunity to have a nimble process that will get us where we want to be, and that's why I suggest that. Leon.
Yeah, but I think there's a lot of agreement that we would like to do something. I think when we say it, I think there's differences of opinion about what, and I think everybody in this room could envision something useful to get done by the end of that date. I think the question is, what is it? What is it? And you keep sort of going from I to we in terms of the decision. I think it's not just people, you hearing the things. I think people are raising issues about how the decisions will actually be made and what's the equity of the decisions and where the resources are coming from. And decisions have already been made. There's already been people identified as project directors. I think people want to hurry, catch up, and make sure that it either say this isn't going to work, or that it really is collaborative. But there's a lot of stuff that already seemingly is been not necessarily finalized, but there have been people that have been identified as having certain jobs. Community people could be doing those jobs also. I mean, I think people are just raising, how making it, as you said, really transparent and not just being heard, but that there is a process by which there'll be some value to the community in terms, not that the assessment will only be an assessment, but by the process of creating the assessment, there's some tangible positive outcomes that accrue. And I think people have made some suggestions or suggested sort of outcomes and things that process would not just have something at the end that started September, because you weren't even talking about finish. My understanding was it wasn't September was the deadline to finish it. That was to start implementing it and resources being raised, because people have raised this also. The funds don't exist to do whatever the it is. I mean, again, if I understand.
Let me be clear. Let me just be clear if I wasn't clear already. There are no funds right now to do anything. There are some funds committed by the Urban Health Institute to plan this. The committing of those funds by the Urban Health Institute are for certain things. And this is what we have. As a part of being asked by Bob Blum at the Urban Health Institute to lead this, I agreed to, with whoever, my goal on the funding slide to say is just me, is not to say that I'm the one that's going to be only one, was to say that nobody stood up and said, hey, I want to work with you on funding yet. That's all that means. That if there are those people out there, I'm more than happy to have anybody work with me. So let me be clear. There's no money. There is some money to do the whatever we decide it to be. There is some money on the table to plan it over the course of the year within certain parameters. This is not an entirely open-ended process like we had before. It's just not, because the Urban Health Institute has said here, this and this. We can decide if that's not what we want to be a part of, but that's what we have.
Whew. A couple of things, Chris. I didn't know that that process was so tedious before. We didn't see what you just relayed to us. We saw it from your end being much more strenuous than from the community side. One of the major problems that we saw was not that every time you talk to someone, but whatever the outcomes were. When you report back to somebody, you can have any conversation you like, but the end result is what you need to report back so we can see if that fits with our agenda. That's what we asked for in the give and take, and that's what we gave you on the other side. When we told you that certain community people didn't feel comfortable with certain things, it was because of that. But you made it seem like we bogged down that process. We came to the table with open arms.
No. Leon, let me be clear. I'm not blaming
No,
you.
I didn't
I'm
say it.
saying
No, let me finish. We came with an open mind and everything because we are actually trying to see how we can mend a lot of these broken fences. We told you that 18 months ago when we did that piece, and we're telling you that again today. To mend the fences, you gotta be really transparent. You gotta have community working side by side with you so that they can carry the message to the community and make it easier for you and Hopkins' perception. Now, you hear a lot of negative things about Hopkins. There are some things that they do very well for certain areas of the community. It never gets relayed because the worst things just overbears them. And if you want to change the perception, if you want to change the way they do business, then we need to work together. It don't mean that Chris lay out this thing and we fall in line and say we're going to get on this team. We can very well adopt almost everything that you had up there. But you need a community person pushing that agenda as well. I certainly hope that you're not going to throw these students out in these communities and tell them to get raw data for you. I would surmise that most of the research that Hopkins has to date is flawed. And I say that honestly because I have personally seen students scared to death sitting in their cars checking sheets on the survey forms. And we told you how we could work that out so it wouldn't be as something that was frightening them to death. We asked that we train community people to go out in tandem with them so that they're never alone, so that the people feel comfortable in the community and you get true data. We asked that. We came to the table. We had all types of options laid out. But Unlike this time, they came to the table, they told us they had funding. I didn't miss those meetings. I came to each one of them. We had a funder at the table, Chris. Casey Foundation was right there at the table. And they were ready to put money into this thing, but we couldn't get it off the ground because upper echelon at Hopkins would say something, and you all were acting like you were afraid to death to bring them to the table so we could talk openly. You know, if they had to say it, let them tell us. That's all we asked. We didn't ask that you shield us. We can handle it. Let them tell us. They need to come to the table, and I hope Mr. Frank would carry that message back, because even with the president, we haven't seen him since last year when he had this big thing talking about how much he wants to do for the community. Come on, do it. We wait. You know, that's what we're talking about, working with the community. If you say you're going to do it, do it. If we say it, we're going to do it. And that's where the community person will be. He can make sure that those things are carried out more so than you. So if you want us to lockstep with you and do this the right way, don't make it a Chris Givens show. Make it get a committee. Don't have to be you or one other person. Make it 4 people or something. But have the community at the table. You said something about the funding. We didn't ask you to raise the funds. You just put that on the table. You didn't say a month ago that I need somebody to help with the funding. I need this, I need this. You didn't say that. You said we were going to meet and talk about this process. And that's what we thought we were doing. I would definitely help you with the funding piece, because I know that this, if it's done right, it will bring in some dollars. And see, another piece is the community don't want it to just be Hopkins dollars, or that Hopkins getting paid. They have people on salary, there's doctors and so forth getting the majority of the money. Then crumbs come to the community to support whatever efforts they have. So understand what we're saying clearly. We want to do this. I don't particularly care about doing it, because if we ain't going to have access to health care, you know how I feel about another needs assessment. I never hide what I'm feeling. And I'm bringing that from the center that I run, where I see people that are hurting all the time. We average 400 new people every year, not to mention the thousands that we see that are return persons. So, you know, these are not things that I'm making up. I know what they're going through, and I want to see a change come. I don't want to just see status quo. And this is a chance for Hopkins to paint a new face on the top of everything. All of this stuff in here is so many negative connotations whenever you say Hopkins that it's ridiculous. And we look, if you want to change it, we here for it. You know, he made a very good point. It can't look like Chris Givens is the only one spearheading this. It cannot.
Okay, here's what I suggest. We make another work group. We make a work group that's going to think about this issue and decide how this will be run, how this will be the leadership of this group. It will be just like all the rest of them. It will be open to whoever wants to be on that group. One thing, though, if this group takes 6 months to decide, we will have failed before we start. So I would ask, because we all want this to happen, and it can happen, that this work group come together. You decide when you're coming together, how often you need to come together, but you've got to be able to decide. You can't take all year to decide this. So whatever the right amount of time is so that we can then put it in place, we need to do that. Maybe it's, I don't know.
Chris, I think we should set a deadline on
Yeah,
that.
well, that's where I'm going to. That's exactly what I'm saying.
Today.
Yeah, well, actually, I was going to suggest one. Do you have one, Isaac?
I would want, as I've said, I'm new to this process. I thought there was a presentation that was made and you could comment on it. But you totally said to change that framework. I don't get it.
Well,
I mean, I don't understand. As I said, I was not part of the earlier process.
yeah.
But, you could comment on what is there. But because if you do that right now, you would lose many of us. I mean, personally, I mean, this is very, as I've said, if there was a framework in place, you could comment. Okay, let's change it, let's change that. But to somehow brush that aside, because, as I've said, of all what I've heard, what's your name, Leon? And what he has said, nothing that I listened very carefully, nothing that I heard you say were not captured by the framework that you put together. So if the issue is because Chris Gibbons prepared this ahead of time to facilitate the conversation, despite the open process, then I think that shows how broken the trust actually is. From my perspective, but I think, Andy is here, but that's the part that I don't get. I don't, to formulate another group, you said you met with the community groups, and you met with Hopkins folks, okay, and we had series of conversations to get me here. So, to again sort of wipe that off and say, let's start over again, I don't get it.
Well, okay, go ahead. I'm sorry, that's Amy.
But I was just going to say that if you go back to that slide, the circular slide, I mean, part of what you just suggested is already on there. We have the community university sort of overarching advisory group. So just to put that back out there.
So again, I could say a lot of things, but again, I think every part of this is fine. I don't have a problem with us discussing changing any part of this. The only thing that we have to be mindful of is we have a window. So what I would suggest is if there are those that feel this is a substantial issue, we should discuss it. But we have a limited amount of time to do so. And let's make it an open process. Let's make it a transparent process, right? Here's yeah, apart from the process that has been demonstrated, the open-ended process that has been demonstrated in the past. So that is what I'm a little bit anxious.
So it sounds like, because it sounds like there was lots of thoughts that the material that you presented, the various topics, the structure were they were fine. I mean, not perfect. People may have comments, and you've asked for people to give comments. It sounds like how the co-working together, how the collaboration comes together, people would like an opportunity to discuss. I think what you're saying is, whether it's August 30th, we need to have that discussion and come to,
Right.
figure out what it's going to
That's
be so
exactly
that
right.
people have an understanding
That's right.
soon. I don't hear anybody saying we shouldn't do it soon. I guess one question is do people feel it would be possible to meet before August 31st? And just, is this impossible for anybody? So I think finding a time, we can either make this space available or, evening is probably better for folks. I'm just trying to figure out, for those who want to discuss this, I'm just trying to find out.
Well, we can do it the same way as I'm saying, all those. We will let's put a piece of paper, as we have all the groups. Anybody who's interested in discussing around this issue of leadership, the leadership structure or whatever we want to call it, put your name down on the piece of paper, put your contact information on the piece of paper. We will be reaching out to you to schedule series of times, whatever it takes within the next 30 days. We got 30 days, I think. If we start taking 2 months and 3 months to do this,
I don't hear anybody saying it. But people are saying they need to set up the meeting.
Just give me a second. So I'm just giving the rationale of why I say 30 days. we can come, if we're all committed to this, does that sound like a reasonable plan? If we are not to come up with what you think the group thinks would be a reasonable plan. Does that sound reasonable to folks?
And since you have lists of everybody who's here, maybe if we could have 2 or 3 of them, and they can just list which committees they'd like to be on, if they want to be on any, next to them, as opposed to creating a whole new, because that has everybody's contact information. It'll be easier for the staff then to produce the list.
Working groups are listed up at the front. As people are leaving, they can sign up.
Yep, we already have them, because this is the plan that we thought might work and we wanted to present to you. Already there, we'll just add another sheet for this one, and we'll move forward in the same way. And we'll approach it the same way. Does that sound reasonable? So this decision, though, we will agree, do we agree that we must make a decision on this by the end of the month? Do we agree? Yes? I'm hearing some yeses, I'm seeing some nodded heads. We are agreeing that this group, if they want a different leadership, will articulate it, and we will agree on it before the end of the month. Yeah. This is what I talked about when I say total engagement. When I talk about accountability, coming here and talking about the problems you see is not enough. We got to work to fix them. And if you're committed, you think this is a real problem, then let me see you work to fix it. And I'm working with you, and if we can fix it, we should fix it. But we can't talk and complain about every single thing, and we put in place a mechanism to fix it. Oh, complain about that too. So here we go. We'll take 1 month, put your names on the list. We'll go forward, we'll look at this, and the decision will be made in 30 days. Yep.
Yeah.
Articulate very succinctly why you chose, I don't need a big explanation, but why you set it up. Because I didn't, guessing a little bit, I think I know why. I was around before, and I think I know, but it wasn't real clear, like, what exactly kind of decision you were making by what you said. And I'd also love it if Leon could sort of put up what he envisions as the right thing. Not what we had before necessarily, but just what is he really looking for? Because I worry that actually what we both want, what you want and what Leon is describing aren't that far apart.
I agree.
So, and if we could just put that on paper so that when the group comes together to meet, we're not guessing at what you were both saying.
Sure. I think that's reasonable. Absolutely. Did Leon leave? Yeah. Did Leon leave? Oh, no, there he is. Leon, are you willing to do that? Are you willing to put on paper what you think it ought to be? As Ann was suggesting?
I actually think you missed what I was saying initially.
Oh, I'm sorry.
Before we sign up for all those different committees, we need to find out who's going to direct this thing. How it's going to be managed and co-managed. I was hoping after I spoke that we would say, let's see who's interested in being on a leadership team. And we would sign up for something like that. But I look out there, you got every one of the topics that you had for people to sign up on. Again, you putting the cart before the horse. I like to see who's going to be leading me before I go to battle.
Well, that's what this group is to decide.
And it wasn't what this group was going to decide, Chris. You asked people to go out here and sign up for all of the different areas, when we should have been just deciding right now how we want this leadership thing to look. Whether we want a team, whether we want co-investigators, what have you. That's what I thought, we should have done, and I might be wrong. I've been wrong before. But I was hoping that we could decide how we was going to do this management team first. And then it makes people more comfortable in some of the decisions they have to make in terms of getting on those committees?
Well, look, I think we need to be a couple of things, respectful of people's time. What I have presented today, as I said in the beginning, were just some ideas as starting points for discussion. They were not determining everything. We were ready in case people agreed that it was a good way to go forward, that they could sign up. It didn't determine everything. Here we are. I think it is reasonable to add one group. If you're serious about this issue, you want to engage in this issue, then let's engage and let's move forward.
Just as a point of clarification, Chris, I think what you presented was very rich and highly representative of a good amount of iterative thought, engagement, and respect across communities, be it Hopkins or the East Baltimore residents and community-based organizations. My only point of raising the question about leadership was that we all come to the table, as you mentioned, with our biases and our
Sure.
limitations.
Absolutely.
And in the absence of ourselves holding each other accountable to a more integrated, balanced, accountability mechanism,
Absolutely.
we sometimes lose sight. And where we have the tensions around an assessment or survey or whatever it becomes, there's also an agenda for health services and training and research and other things that can collude. And so having one person to try to fetter out and retain the integrity of what this is really all about and supposed to be based upon the people who have bought into and are willing to lead, I think it becomes overwhelming for one person. And so the mere suggestion in terms of leadership was more so to just outline exactly how will that operate, not to say that you didn't have that as your goal for it to be as integrated and balanced. So I just, as a point of
That's fine.
clarification.
Again, it's okay. I don't take this as a personal affront. My goal was, and apparently I didn't succeed, was to articulate this in a way so that you would see it is not a Chris Gibbons driven thing. But apparently that didn't come across. So I'm open to discussing it. And if we can make a decision quickly that everybody's happy with, go forward. If we're not, then we're going to have to be left with what we have. But we have to respect people's time. You've been great. I appreciate. We'll take two quick last comments, and that's it. And we've got to let people go because we've got to.
Just one comment.
Yeah.
I think documents.
What's that?
I think once now that you put it on the table, seeing it in documents probably
Sure. Right.
I have one comment. Your timeline, September 31st, 2011, does not exist. September the 30th.
What's that? I'm sorry. What
It
happened?
should be September 30th.
September 13th?
You have the 31st.
Oh, did I? I'm sorry. I'm sorry. All right, Michael, last comment. To look at that, yes, to look at that issue.
Okay, good enough.
Yep.
And so you said, you're suggesting sign up and have the decision made by end of the month?
End of the month.
Okay. And my only other question is the assumption that capital and the control mechanism will go through Hopkins, or are you open to, say, if the Mid-Atlantic Innovative Health Institute, which would pass through to the community and leverage both Hopkins and additional resources they have, if they wanted to lead it, or the Joint Center or someone else, would you be open to that as well? Because you said there's no capital at the table, so if the community can bring capital and an organization that's an honest broker in between them, would you be open to that?
Well, so this was a 2-hour meeting. I couldn't talk about everything I thought, but my thought was that money that's raised by the community stays with the community. That was my thought. I didn't have a chance to say it, so I don't see any problem with what you're saying. But
Yeah, no, I meant in terms of the control mechanism, so not only the money, but the decision factors. Are you, is it open, in other words, if you can bring credible research institutions that represent the community, is the assumption set now that all this will run through Hopkins, or can you flip that on its head? Because that's radical.
yeah, I'm not sure I understand, but
I'm saying there are legitimate there are just as many PhDs in other groups that have attracted large dollars from Kaiser, from a Kellogg, et cetera, et cetera, et cetera.
Right.
That would be an honest broker between Hopkins and the community, but that would allow community building. But that control mechanism would be important to those groups.
Controlling the funds, you mean?
Yeah, the
Control-
process, right. So I'm trying to understand, when
Yeah.
you're saying a co-lead,
So
are you?
why don't you and I talk about
Okay,
this afterwards so that others, we don't TK. Thank you all for coming. Please stay engaged in the process as we go forward. Thanks a lot.